The last session, we have discussed about formation of the sounds. Today I will be discussing about the features of breath sounds heard on auscultation. Breath sounds can be, depending upon the origin. If you auscultate over the trachea, you get a tracheal sound. The sound heard from the bronchus is bronchial. When you auscultate over the lungs, the sound heard is vesicular. The basic mechanism we have already mentioned. Breath sounds are formed in the large airways, and during passage, the high frequency sounds are filtered by the lungs, and that is why you get a vesicular sound. So the term vesicular is a misnomer. They are the changing in the quality or muffling done by the lungs. Lung act as a 200 Hz filter. That is a mechanism of formation of vesicular sounds. Now we look into what are the features of bronchial breath sounds. The bronchial breath sounds are heard over the trachea or when the lungs are damaged, as in a consolidation. So think about consolidation. In consolidation, the airways are patent, but the alveolus gets filled with the fluid, and this is a better conductor. So sound heard from the or produced from the alveoli are transmitted, high pitch sounds are transmitted without modification by the alveolus. So it becomes, what you hear is bronchial. A bronchial breath sound heard over the lung field is most often abnormal. So what are the features of bronchial sound? The bronchial sound has got a tubular or hollow nature and is aspirating. So if you draw like this, it will appear like this. There is no pause between inspiration and expiration in vesicular breath sound, but here there is a definite gap. And the expiration is equal to inspiration or even greater than that. So the features are, it is higher in pitch, aspirate in quality. There is a definite pause between inspiration and expiration, and expiratory sound is equal or longer than inspiration. These 3 points should be there to say it as a bronchial breath sound. Bronchial breath sounds may, or a bronchial character may be heard on auscultation over the trachea, or you auscultate over the cervical spine and the upper thoracic spine up to D3, or close to the sternum. There may be some features of bronchial character. That should be kept in mind. So when you look at a bronchial breath sound, when the lungs are destroyed, but the bronchus is patent. So first and foremost condition you should keep in mind is consolidation. So when it's consolidated, when a patient with a collapse, if the airways are patent, you get a bronchial breathing. Same way the fibrosis. The lung tissue is damaged, but the airways are patent, you may get a bronchial breathing. Along with you should remember one sign called the D-spin sign. D-spin sign is classically described in pericardial effusion posteriorly on the left side, in the lower part below the scapula. You may get a bronchial breathing on the left side. This is called the D-spin sign. In posterior mediastinal tumors also you may get. Now we go into the types of bronchial breathing. Bronchial breathing is depending upon the pitch you divide into a high pitched and low pitched one. Can be high pitched, low pitched. High pitched is called tubular and low pitch is called cavernous. There is another type called amphotic sound. Amphotic sounds are low pitched sound with high pitched overtones. High pitched overtones. As if you are whistling across a hollow tube like this. It has got a metallic quality. So that is point you remember. A metallic quality. Where will you get amphotic sound? Amphotic sounds are heard when there is a large cavity that is communicating, or in a broncho-pleural fistula. Broncho-pleural fistula. That is a open pneumothorax. You may get a amphotic sound. Coming to the low-pitched sound, low-pitched sounds are characteristically seen over cavity. So low-pitched or cavernous over cavity. So cavity, open cavity, you get a cavernous sound. Tubular sound is typically heard in consolidation, which already the mechanism which you have already discussed. So now we go to auscultation of the lungs. The breath sounds heard over the chest is typically vesicular. What are the features of vesicular breath sound? Vesicular breath sounds, the inspiration is a low pitch sound and higher intensity and pitch compared to expiratory sound. There is no pause between inspiration and expiration. And the sound in expiration is heard only during the initial 1/3 of expiration. These are the typical features of vesicular sound. Again, I have already mentioned what is the reason. The mechanism is the high-pitched sounds are filtered. The lung acts as a muffler. And that is the reason. It is not formed at the vesicles as taught by Laennec. Some changes in the quality of breath sound when you auscultate over the upper part and the lower part may be there. But what you should look for is there any difference between both sides? So when you are auscultating, corresponding areas to be auscultated. So go like this and all the areas to be auscultated systematically. Difference between sounds between two sides, that is more important. The same lung or same side, upper part and lower part, the sound may be different. Keep this in mind. Then on auscultation of the lungs, you may get a bronchial character sometimes, and such breath sound is sometimes called broncho-vesicular sound. So what is a broncho-vesicular sound? Broncho-vesicular sound has got some features of vesicular sound and some features of bronchial sound. So the inspiration is like this and the expiration is prolonged. So it is actually a vesicular sound with prolonged expiration. It may be a little more louder, and this sort of breath sounds may be heard in bronchial asthma. That is a typical condition you should remember. Bronchial asthma and chronic bronchitis you may get. A bronchovesicular quality may be seen when you are auscultating near the mammary sternum anteriorly and posteriorly in the interscapular region. So today we have discussed about the vesicular sound, the bronchovesicular sound, the bronchial breath sound, the different types of bronchial breath sound, and the DSP sign. When you are auscultating, three things should be looked for. One is intensity of the sound. Second, is there a pause between inspiration and expiration? Third, what is the length of expiration, or what is the duration? Is inspiration or expiration which is longer? What are the abnormalities of the sound, the normal vesicular sound we can get? Suppose when you are auscultating, the sounds may be increased in intensity, especially when you are auscultating a thin-walled person. The sound may be, or frail person, you can get it, or especially in children. Intensity may be decreased. A thick-walled person and also patients with emphysema. So emphysema, the breath sounds may be decreased. Suppose there is a pleural effusion. Over the pleural effusion, the conduction of the sound will be decreased. So breath sounds will be decreased in intensity. Just like somebody with the fibrosis also can have a decreased breath sound. So intensity can be increased, intensity can be decreased. That's what relevance only when there is a difference between both sides. Other characteristics of vesicular sound, the difference between different areas we have already mentioned, and the bronchovesicular sound also we have discussed. Hope this was useful to you. In the next session, we'll come with the adventitious sounds. Stay tuned. Thank you.